Welcome to another episode of Brain Buzz. This is your host, Dr. Kimon Bekelis.
And I'm your co-host, Jason Wallen.
Well, today, we always say we delve into the fascinating world of neurosciences and brain health. Today, we're jumping off the deep end, and we're very, very honored to have one of the geniuses in our field, one of the, I would say, the folks that have shaped the field of neurointervention and stroke neurology and the way we practice on a daily basis. And this is Dr. Albers. He's with us, calling in, I believe, from the West Coast. Unfortunately, he's not able to be with us in the studio, but certainly a great honor to have him here. Dr. Albers, welcome.
Oh, thanks so much. Yeah, I'm at Stanford. Sorry I couldn't be there live and in person.
It's our pleasure to have you with us. So, we're going to talk a lot about exciting things today and talking a lot about the cutting edge of technology and innovation and research when it comes to stroke and the care of these patients that we all deal with on a daily basis. And maybe for our audience who might not be familiar with you, kind of the general audience, of course, all of us in neurointervention know who you are, but maybe for our general audience and our patients that are listening in, tell us a little bit about who you are and how you came to be who you are today.
Sure. I'm a stroke neurologist, and I've been at Stanford for a long, long time. Arrived in 1984 and did my training, including neurology residency and a stroke fellowship, and then started on the faculty in 89. In 92, we started a very unique center called the Stanford Stroke Center that brought together neurosurgery, neurology, interventional neuroradiology to work together to improve diagnosis and treatment of stroke. And we've been at this for more than 30 years now and have had the opportunity to do a lot of research into trying to optimize stroke diagnosis and treatment.
Great. And for those of you guys who really don't know a lot of the details behind Dr. Albers' career, he is the person that really changed the way we deal with stroke when it comes to the time frames that we consider appropriate to treat stroke. Generally speaking, and of course, we've discussed this before in other episodes of our podcast, but generally speaking, we used to be able to offer stroke treatment to folks that show up to the emergency room within 3.5 to 4 hours of symptom onset. But after some clinical trials, we were able to extend that window up to 6 hours with more invasive treatments, what we call mechanical thrombectomy. And then Dr. Albers was the lead clinical investigator in a clinical trial called Diffuse 3. And of course, there was other clinical trials at the same time that allowed us to push that window to 24 hours. And that's really changed the field. And all of us in neurointervention are grateful for your work in that and for kind of having the vision to push the boundaries when it comes to stroke care. How did you initially conceive the notion that stroke care can be extended so far out?
Yeah, it started in the mid 90s. One of the faculty members at Stanford, a guy named Mike Mosley, had done some work with different MR sequences and had stumbled onto the fact that diffusion weighted imaging could see a stroke in real time. He was doing animal work with a cat stroke model. And this was incredibly exciting. It was just around the time we'd started the stroke program. And he asked us whether we thought this could be useful for patients. And said, hey, this could be the holy grail of really figuring out how strokes evolve. Because when I was in medical school, and similar to you, it sounds like was taught that stroke was going to be very difficult to treat because all the brain damage happened so quickly.
Right.
So what we started to do was doing serial diffusion MR scans on patients. And what we saw is that these strokes were all different. Everybody's stroke evolved differently, but most strokes were growing for a long period of time, sometimes 24, 48, even some were growing for 3 days. So the idea we had was that if they're growing for a long period of time, that means they should be able to be treated for a longer period of time. And then we needed to work on some way to be able to determine when the patient came in, was the stroke still growing or was it done? And that's when we started using perfusion imaging and then developing the software called Rapid that allowed us to see the area that was dead versus the area that was at risk and was potentially salvageable.
Right, and I think that was that catapulted in a lot of developments with that software. And eventually, all of us, a lot of us are using Rapid, of course, and that allows us in real time to really assess the viability of the brain tissue and make decisions on treatment and incorporate our team into those decision-making um, moments. And, of course, now the company is called Rapid AI, artificial intelligence, right? And artificial intelligence is extremely trendy these days, of course. And so tell me a little bit how artificial intelligence fits into the identification of stroke through rapid and through perfusion images that you described.
Yeah, great question. So way back when we developed Rapid, which was 20 years ago, it was when the software was developed. It was before the AI craze.
Right,
So we were using standard algorithms to be able to identify tissue that was irreversibly injured based on ADC thresholds and MR, and then using Tmax thresholds with perfusion imaging. Uh, as we got to some of those trials that you mentioned, we had to convert the software to CT perfusion because not many places are doing acute MR. We love MR, but
right,
realistically, CP is what these patients had access to in the emergency room. So again, standard algorithms. And then by the trials that you mentioned, Diffuse 3 and Dawn that came out in 2018, really the company started to take off because the guidelines changed and we had a huge number of stroke centers calling and saying, hey, I need this software. So we had been able to get it through the FDA. It was FDA cleared in 15. And at that point, we started to focus on additional modules and AI enhancements that could give you more information to help you treat stroke patients. So we worked on an automated aspect score and
right,
then identifying large vessel occlusions, identifying brain hemorrhaging, measuring the volume. See, these were all AI-based modules
right.
that could give you information in real time to help you make a quick diagnosis and triage the patient. And what was a huge benefit, in my life and many others who take call, is that covering many hospitals at night, I could see the images from all the hospitals in real time. So when I
Right.
get a call from, Santa Cruz or Monterey, I could look at the phone and I could see, is there a large vessel occlusion? Is this somebody who needs to be transferred to Stanford? Or is this somebody that I can help manage by phone and doesn't need to be transferred? So having all that imaging available at your fingertips, that was a huge advance for AI.
Yeah, you're hitting the nail on the head. We've had the same experience when it comes to Rapid. At least, of course, now it's software that's available anywhere you have a handheld electronic device, your phone, your watch, if you have a smart watch, your computer. And so, as a neurointerventionalist, of course, you're not going to be always in front of a desktop waiting for a stroke to happen, especially with the amounts of call we take. So that allows you to organically be anywhere close to the hospital, of course, get those notifications, see the images, make a decision. And another thing that I think you've achieved, maybe you don't realize it as much with the creation of the software, is that the whole stroke team becomes acutely aware of what's going on. And more so than that, folks that are not necessarily trained in medicine, strictly as physicians, but nurses and technologists and a bunch of other folks are now able to interpret perfusion images because they get them on their phone all the time, and they're used to knowing when a stroke is a go or not. And often, I might be doing a procedure, treating an aneurysm, for example, not paying attention to my phone necessarily, but the notification will come in, and my team will tell me, there's a stroke, it's a go, and it's not my nurse practitioner, it's not my PA, but it might be my technologist or somebody who, traditionally would not be reading perfusion images. And so you kind of allowed everybody to be part of this exciting field and be part of the decision making process. And I think that is spectacular. I don't know that there's any other field where everybody has access to such wealth of information, and then now they are able to interpret it also very effectively.
One of the surprises, Jess, is the uptake by some ER docs,
Right.
because ER docs have typically not really been terribly oriented to
Or interested.
detailed
Yeah.
neurology. And one of the things I know that frustrates them is when they call to transfer a patient and when a neurologist is asking all sorts of questions and
Right.
they really just want to get a yes or no answer and move back into their ER.
Right.
And so now we get calls from ER docs that say, hey, the rapid shows there's 50 cc's of salvageable tissue. This looks like a great case. And the
Right.
answer is, yeah, we send the helicopter, send the ambulance. And
Right.
it's huge time saved to be able to make the triage decisions quickly. And then also what we've found is that when we transfer patients where we've seen the imaging, then it's a high yield transfer
Right.
that they virtually always get a procedure rather than before we had the imaging, you were kind of taking a stab at a guess and you never know what was going to show up
Right.
when the ambulance helicopter arrives.
Uh,
So it saves a huge amount of money to have, quality transfers, the really patients who need to be transferred rather than transferring somebody who could be managed at an outside community hospital.
Absolutely. Let me ask you, do you see much value in, um, or rather, let me change the question. If you have a satellite hospital like we have and like you have that has rapid, and they're assessing the brain tissue at the time of course, of presentation in their emergency room, and there's a large vessel occlusion, there is penumbra or area that can be salvaged for the non-medical folks, and we say transfer the patient, we'll try to open the vessel, the patient comes back to our hospital. How do you feel about repeating the images, understanding that of course time has gone by and at that point you might be looking at much larger area of completion and maybe a case where you wouldn't really be able to help and probably put him at risk? Would you repeat the images, or would you just accept the images that you got in the outside facility?
Yeah, that's a great question. Depends on a number of factors. One is how long did the transport time take?
Right.
We also, if they've done perfusion imaging, which most of our outside centers do, we can look at the collateral pattern. And
Hmm.
if the patient has good collaterals, we can be confident that there's very unlikely to be much change during a couple hour period of transferring the patients. The collaterals are poor, which we use this thing called the HIR, which tells you how severe the delay in the arrival of the contrast is. If the contrast collaterals are poor, then we know they're much more likely to have significant growth of the stroke during transport. So those patients that were more anxious to reimage. But something brand new that we're really excited about could really answer your question even better,
Sure.
which is we now have perfusion imaging off the cone beam, the C arm from your angiography equipment.
Right.
And FDA clearance is anticipated very shortly. We've already done some studies that show it gives very comparable images, and it takes a minute. So one of those patients who maybe it's been 2 or 3 hours in transport, you don't need to worry about taking them to the ER for another scan. You can go straight to the angio suite, do the cone beam CT perfusion, and then you can find out, hey, maybe they recanalize because they got a thrombolytic and
Right.
they don't need to have a ephemeral puncture, or as you said, maybe the stroke has gone on to completion, there's a massive infarct, and we don't want to do the procedures. So I think that's going to be the wave of the future, is to get that perfusion imaging on arrival at the angiography suite.
Yeah, that's fascinating. Yeah, and we are actually working on a study anticipating that this will be available. We're working on a study in our two rooms. In one room to follow the traditional path of getting images in the emergency room, and then in the other room to have the kind of point of care images that will guide care and see if the outcomes are better in terms of delays and in terms of functional outcome of the patient. So um, that's really fascinating. And so where do you see
Yeah,
that?
I'm going to make one other
Please.
point about that that's we've been really excited about lately, is that once the procedure is done and things look pretty good, uh, the assumption is, oh, we've done the job and the brain is fully perfused.
Right.
But what we've seen from some studies done recently, including a very nice study in Barcelona, is that there are often patchy areas that are not fully reperfused, and patients who are not fully reperfused have worse outcomes. So one of the things that you can do, in addition to finding out, before you start the procedure where you're at, once you're done, you can do another quick C-arm, cone beam CT perfusion, and you may see that, hey, there's still some patchy areas, small vessels that are still occluded. And this opens up the opportunity for intraarterial thrombolytics, intravenous thrombolytics, new neuroprotectives to try to really take care of those patients who didn't get 100% reperfused in the cath lab. So we're very excited about initiating some studies to look at that as well.
That's fantastic. You mentioned neuroprotectives. Um, of course, we all know that that neuroprotectives are agents that we give to patients to protect the brain and minimize the impact of stroke. Haven't fulfilled the promise that I think all of us hoped they would. How do you feel? Do you feel that this is going to change in the future? Or is there anything exciting, new and exciting out there that might allow us to use them again?
Absolutely. It's a great question. And, we've been involved for decades with neuroprotectives and obviously been disappointed. But I think part of the problem is that they haven't been given to the right populations. When we were doing these studies 20 years ago,
Uh-huh.
we didn't have any idea who had salvageable tissue and who didn't. A lot of lacunar stroke patients were being treated, patients with completed strokes. And the more recent studies, what they've focused on are patients who come into the comprehensive center about to get thrombectomy and they get the drug, right as they're about to get treated. And they've particularly selected patients with good collaterals. And as I said about the transfer, if you've got really good collaterals, you're not in an active growth phase of the stroke. So that's not who needs the neuroprotectives. The
Right.
neuroprotectives are needed for patients who the stroke is actively growing. And the perfusion imaging can give you a very nice answer to that question. We've had a series of papers that have come out over the last few years showing that you can make a very accurate prediction of how much stroke growth is expected over the next couple of hours based on the perfusion imaging. So if you have a patient at an outside hospital and they are predicted to be having an actively growing stroke core, that's perfect for the neuroprotective agent. Give it at the outside hospital and freeze that stroke during transport. If you're getting somebody who's going to have a very short time before the thrombectomy, rather than treating the good collateral patients, again, treating patients who have active growth, I think is more likely. So to benefit. So a number of the companies that have these promising agents are starting to use the AI growth prediction to try to determine who do I want to put in my study. And I think we're going to see much better results as we really get the right patient population treated.
Yeah, that's really fascinating. Um, Addressing stroke from all directions, I think, is what's going to minimize the impact of this disease. And of course, we've made tremendous progress over the years. From I would say since the big trials that allowed thrombectomy to be used as a standard of care in patients, uh, the field has made tremendous progress. I'd say probably more than all the years in the past. These last few years, it's been cataclysmic, the progress in stroke care. And where do you see that whole thing going? Of course, you mentioned neuroprotectives, but also in terms of the use of artificial intelligence and other modalities. What's in the? Can you give us a window into the future? Since of course you've been a visionary for a very long time when it comes to stroke.
Yeah, I think there's a lot of really exciting things that AI can do for us. One example is Rapid has a breakthrough designation through the FDA to allow AI modules to work together. There's been a huge proliferation of AI companies and AI modules, and you can imagine that a patient comes in, they get a scan, and suddenly your phone lights up with 10 different results,
Right.
right? And some of those results may not be applicable to that patient. So one of the modules that was approved last year is one that actually starts off with the non-con CT and squeezes a lot of information out of the non-con CT. For example, what it does is it starts and it looks for hemorrhage.
Okay.
So if you have brain hemorrhage, you're heading down a different path. So then you're going to want to know what type of hemorrhage, what's the volume, is there midline shift, if it's a subdural, what's the width of the subdural, all those type of things.
Right.
Where if it's not, if it's ischemic, then what you want to know is there an LVO? And so what the software does is it looks for the hyperdense MCA sign, and it also looks for early ischemic changes within the middle cerebral artery territory. and it's able to pick up 2/3 of the MCA occlusions off a non-con CT alone. And one of the reasons that's important is that as we surveyed, hospitals through the Rapid Insights database, Rapid is at 2,200 hospitals, and so the
Right.
data comes in on, when did the non-con CT get done? When did the CTA get done? When did the CTP get done? And in patients who were eventually found to have an LVO, there's a large number of hospitals where there was a delay of 30 minutes or more between the non-con CT and the CTA. I don't know if you see this in your practice, but we have a couple of hospitals where it's not unusual. They call us with a perfect thrombectomy candidate, and we find out that the patient's been in that ER for an hour and a half or 2 hours.
Right.
And part of the reason for that is they do a non-con. Neurologic symptoms is the knee-jerk reaction, get a non-con, pull the patient out, think about it, talk to the telestroke person or the radiologist, and then they say, hey, you need a CTA in this case. And
Right.
by the time they get the CTA that shows the LVO, there's been a lot of time.
Right.
So by using this breakthrough designation product, we can get an idea right away on our phone that there's an LVO out there at the community hospital X.
Right.
And then we can say, either we need a CTA immediately, or we can look at that hyperdense MCA on our phone and say, this is a winner, send the ambulance, transfer this patient right away.
Right.
So the future of AI is getting the software to tell you more than, something is suspected. It's really drawing you to the point of saying, hey, I've got a subdural that's got midline shift. This is an emergency.
Right. Right.
Go
Right.
after this right away. Where this is an LVO, I can pick this up off my non-con CT. Again, this needs attention right away.
Right. And you mentioned the delays between the basic modalities like a plain head CT and the more advanced imaging, which is the CT angiography, CT perfusion. And you're right. We saw that when we were starting our program here before we're a comprehensive stroke center, there was a bit of lack of ownership of the patient from the moment you got the CT to the decision to get a CTA or CT perfusion. Because of course everybody was focusing on the thrombolytic, on the clot busting medicine, the TPA, the TNK, but the second part was lacking. So we've introduced a separate code, stroke code, that was specific to possibly interventional cases with very strict criteria to be called by the emergency room. So much so that even if you didn't have neurology input, you'd be able to activate that. And we would see delays like you described, an hour between CT and CTA, and that brought it down to almost nothing, to negligible, because now the second a patient comes out of the scanner or is in the scanner, there's a decision for thrombolytic. Immediately after that, the emergency room will, in the algorithm that we've created, they're asking the question, is this a candidate for the upgraded code? And then they proceed with that. And so that cut down. It was one of our success stories when we created the Comprehensive Stroke Center. That allowed our team also to be activated. That new code would indicate to the neurointerventionalist he or she will get a phone call and be notified, hey, we're getting a CTA, CTP. So now they know that their phone is going to beep any second with a rapid notification that, there is an LVO or there's no LVO. But regardless, they are involved in the care instead of not being involved. And that's key, right? Of course, we are in this field and we understand that time is brain. That's what will make the difference in these patients. And I always say, us on the neurointerventional side, we're glorified plumbers. We open blood vessels. We can open blood vessels all day long. What's going to make the difference is when we do that. And that's why stroke is a challenging disease. Stroke starts from the community. When somebody's having a stroke, identifying it either themselves or somebody who's a bystander, if you miss that first step, it doesn't matter how advanced you are in the back end. It'll still be for nothing. But it starts there, then it goes into effective EMS systems that will bring that patient to the appropriate facility, either an appropriate primary or comprehensive stroke center, depending on the rules that apply in every region of the country. And then, of course, administering the right treatments without delays, such as, an hour and a half between imaging modalities. And I think organizations nationally are also recognizing the need to bring those times down to almost nothing. We're held to extremely high standards. From the time somebody shows up in the emergency room to revascularization, we're looking at 60 or 90 minutes, depending on where the patient is coming from. And that can be very challenging. I think cardiology is held to similar standards, but all they do is an EKG, whereas we have to do the most advanced imaging, administer controlled medications that are potentially dangerous, and then do revascularization. So I think that has really, those mandates have really made our teams very, very strong. And having a product like Rapid has really allowed that to happen. Without that team integration and the availability of images right away and the notifications and everything that's going on, achieving those times is nearly impossible.
One of the other things that we noted as, we had these change in guidelines and all the focus on thrombectomy is that you had a huge number of CTAs getting done, throughout the country.
Right.
And the radiologists were really focused on, is there an occlusion? Do they need a thrombectomy? But when you look carefully at these scans, aneurysms were being missed, that about 3% of the population has an aneurysm.
Right.
And it's easy to miss it when they've got something else going on. So one of the other advantages of AI is being able to screen through those CTAs and pick out who's got an aneurysm. And then in a more sophisticated way, we developed AI software that could measure the aneurysms and give you the surface area and volume, which is a much more accurate way to assess the size of an aneurysm and the shape of an aneurysm. Because if you're not going to coil it or clip it because
Right.
it's too small, you want to be able to follow it. So having AI follow the aneurysm so you can superimpose the follow-up scan on the baseline and really say, has there been a shape change? Has there been a size change that's going to lead us to want to treat this aneurysm? And we're, very optimistic that this software is going to prevent a substantial number of subarachnoid hemorrhages.
Right. And I'll tell you my experience, when we started this program 7 years ago, I always used to say to my team, we need to create a database of aneurysms. We need to follow these aneurysms. We need to know what's going on with them. And we did. But, it's one thing to have a 2D, two-dimensional image where, you measure, and of course you're dependent on the radiologist yourself, where you're going to put the measuring areas and get a measurement of the aneurysm. And of course, we all know the limitations of these studies and the angles every time and the positioning of the patient. And we're looking at millimeter level changes or sub-millimeter sometimes.
Yep.
And, people probably don't understand how small the aneurysms we treat in the brain are.
Tiny movement of the mouse, right? A tiny movement of the mouse could say this aneurysm is growing when it's not, or the aneurysm is stable when it's actually growing. So
Absolutely.
that's a great example of your question. What can AI offer? It
Right.
can offer much more precise measurements than what a single linear measurement from a human hand
From a
can
human.
offer.
And so, when rapid aneurysm became available, I think we were one of the early adopters because we were primed, especially because of my desire to see this happen. And when I saw it unfold, I thought it was an absolutely amazing idea, and we wanted to be part of it because, it gives you two two important components. It has two important components. One is, of course, the fact that you are able to identify aneurysms that maybe you can miss. Of course, humans are prone to make mistakes, and so having this safety net to identify things that might get missed is very important. And of course, get very detailed images. We get 3D images. We get shape. We get the shape of the aneurysm. We get multiple measurements. We get to assess the dome. We get to assess the exact location. It almost is as good as an angiogram often, and it allows us to make decisions about whether we need to proceed with an angiogram, whether we need to decide on treatment, whether we need to monitor an aneurysm. And the second component is exactly what you mentioned, which is monitoring these aneurysms. And sometimes, even if there's no per se size change in our limited ability that we have in the two-dimensional images, a shape change can be as equally important when it comes to aneurysms because, of course, it indicates maybe another soft spot, another possibility of rupture, and that can trigger treatment for those aneurysms. And our experience, we've really, really enjoyed working with rapid aneurysm and getting that information. again, the same thing applies here. The whole team is getting those notifications. The whole team knows there's an aneurysm that's been discovered, and they're working into further investigating the aneurysm, identifying the appropriate path, albeit either observation or intervention or an angiogram. And so it almost, and our name, by the way, is the Stroke and Brain Aneurysm Center. So, of course, neurointervention is not just those two things, but of course, you can tell these are our passion, right? And so I think rapid and artificial intelligence has really helped us bring our practice to the new level and to a new level, and to allow the team to be more cohesive and treatment to be more effective and accurate, right?
Yeah, definitely.
There's a lot of research that can be done with this software. We were very excited to see this paper that Dan Saline and his colleagues from Ascension put out a little over a year ago in JNIS, where they look back at the most upsetting cases that you encounter, which is when you're following somebody for an aneurysm and you do the scan and you tell them, hey, it's stable, don't worry about it, it hasn't grown, we'll see in a year for another check.
Right.
And then they come back a few months later with a subarachnoid hemorrhage. So fortunately, that doesn't happen that often, but he took the cases like that and retrospectively fed them through the rapid software where you could co-register the last two scans. And what he found is in all of those cases that ruptured unexpectedly, there was growth that could be picked up by the software. So
Right.
I think, again, it's telling us that our standard method of having somebody draw a line to say how big it is really is suboptimal. Having a more
Right.
sophisticated AI approach is going to be a much better way to help prevent these subarachnoid hemorrhages. And Jeremy Haidt, who's an interventionalist at Stanford, did a study where he looked at the measurements that he makes in the angiography suite and compared them to the measurements that were made with the software, prior to the procedure. And he found there was a perfect match. So he said, this can save me a lot of time. I can take the measurements from pre-op and
Right.
decide what device am I going to use? What size device am I going to put in? So I think there's a lot of potential for research with this new module, and it's really exciting to see what happens when you give a new tool to academics. They can really help clarify what it can and can't do. And I think it's important to point out that AI has limitations as well, that there are
Right.
going to be false positives and false
Right.
negatives, and people need to be aware of that, because we've done a number of studies that show it's really the combination of the AI and the physician that's better than either alone, right?
Right.
The AI can point out some things that the physician missed, but the physician can also look at the AI and say, hey, look, the software got fooled by this artifact, right? So if you team them up together, you're going to be better than either alone. So the idea is not that we're going to use AI to take the physician's job, but to make the physician's job more efficient, more accurate, and improve patient care.
How you doing, Dr. Alberts? Jason here. I'm in awe because it's like
I'm
talking
great.
to the Bono of stroke care. Here we got, we see that what Rapid did for stroke, and now we implemented Rapid aneurysm ourselves. Where do you see that taking aneurysm treatment and detection and all that in the future? Is it going to evolve much more, or?
Yeah, it's going to evolve. So where we're at right now is you have two different aneurysm products. One, which is called a triage and notification product, which can screen through your MRAs or CTAs and very quickly just flag an aneurysm is suspected in this case. And it can do that in real time. To get the detailed measurements that we're talking about, currently it takes a bit of time. So, one of the things that Dr. Bekelis and I were talking about beforehand was that that bit of delay is not desirable. So we're trying to really speed up the more sophisticated aneurysm software so that you're going to get that in real time as well. So not only do you say, okay, it's here, and oftentimes these patients have more than one aneurysm, so you're coloring them in different colors and you're giving them measurements, and we need that to come out right away. So before the radiologist reads the scan, they've got the advantage of the AI there, so that you just have one radiology report rather than one, and then subsequently you say, well, look, I looked again with the help of some software, and there's actually an aneurysm that I missed. The other thing that we need to do is better predictive models, right? So that we take the information that we've been talking about, the shape change, the size change, and we say, this is going to tell us rupture risk. So we can really identify for a given patient, how high is the rupture risk? Because if you get to elderly patients who are going to be at higher risk for procedures, you got to make sure that the risk of the procedure is going to be worth the benefit of preventing future risks. So I think using the AI information along with other clinical factors about the patient are going to eventually lead to rupture risk scales that are similar to scales we have in all sorts of medicine. What's the risk of this AFib patient having a stroke? We
Right.
want to know what's the risk of this aneurysm rupturing in the next year, the next 5 years, or the next 10 years. So it's going to be combining the AI information with clinical data. Another important thing that we're trying to figure out is how much volume change is important, right? Because you can imagine, even with sophisticated AI software, there's going to be a little bit of measurement error, right? If you take the same aneurysm and you scan it 3 times today, is it going to show the exact same volume, or is it going to be plus or minus 3%, right? So if it's plus or minus 3%, you know that a 3% change is not something you need to worry about. But when you start to exceed that normal variability that you would see repeat scan of the same aneurysm, then hey, I've got something where this thing is growing. And risk factors for rupture, growth appears to be very important, right? So size matters, but any neurosurgeon is going to tell you that they've seen very small aneurysms cause subarachnoid hemorrhage. So why did
Unfortunately.
that small, yeah, why did that small aneurysm rupture? And a lot, I think, has to do with morphology and growth change, right? If it's small but it got bigger, it's still small, but it's at high risk to rupture.
Right. That's very insightful. So, I'm sure we can be talking for hours about all the exciting things that are coming up, and of course, all the exciting things that you're doing. I want to ask you a couple of questions that we ask all our guests, and one has to do with, of course, education. I'm sure you've educated countless trainees, medical students, physicians, residents, fellows over the years. What advice do you give to folks that are interested in stroke, that are interested in entering the field of neurology, neurointervention, neurosurgery, neurosciences in general, as somebody who has trained a lot of them?
Now, we started our fellowship program in '92,
Oh, wow.
and some of my early fellows have already retired, which is kind of upsetting to think my trainees are retiring, because I feel like there's so much more to do, that with these recent advances, it's really opened the door for all sorts of exciting things. Like we talked about neuroprotection,
Right.
trying to take what we've learned in adults into the pediatric population. There's a ton to do. Uh, we just did our ranking for our fellowship yesterday. We had over 150 applicants for
Oh,
the
wow.
stroke fellowship. So people are really excited, not only about going into interventional, but also going into vascular neurology. And nobody's having trouble getting a job. There are all sorts of hospitals that want to be able to offer stroke care, so that we won't have to transfer so many patients in the future, right? We've
Right.
got hospitals who are starting neurointerventional programs. We were getting vascular neurologists in community hospitals to help decide who needs to be transferred, as well as to be able to intervene when they come in first, right? As you said, when somebody's first picked up by the ambulance, that infarct is growing, right? We want
Right.
to stop the growth as soon as they come to medical attention. And right now they go to community hospitals, and there can be a lot of growth between the time that they get to the community hospital and the time that they get to you to do their thrombectomy. So having
Right.
vascular neurologists at those hospitals to administer thrombolytics, neuroprotectives, I think is going to make a big difference. So it's a great time for the field, because there is just so much happening, right? We're going out to smaller vessel occlusions, right? We're doing our MEVOs and distal vessel occlusions and trying to explore the limits. We've had a lot of interesting information about large core studies that have come out over the last year, and there's a lot more to tease out there. So that's another, frontier. When is it, futile? When is it too
Right.
big to go ahead? So we really, have so much to do in the field it's a very, very exciting time. As you said, there was, 20 years ago, there wasn't that much we can offer. Now there's a ton that we can offer, but we still have, at least half of our patients winding up disabled who come in with large vessel occlusions, even if they're optimally treated. So we got to go after that other half, right? We
Right.
need to, improve the overall outcome of stroke. So there's tremendous potential. How can we improve our own collaterals so that, when we have a stroke, we're going to be the patient who has the great collaterals who can get the late window treatment. So many really exciting areas in the field to go after.
Absolutely.
You had mentioned the different areas in the field, and one thing that I noticed when we were doing a little bit of our research on you is you had said that one of the reasons that you had got into the neuro field is you were interested in memory. And do you see anything with AI and memory? Because we have a lot of different patients that after a stroke they have memory issues. Is there anything on the horizon for that you can touch base on?
One of our faculty members at Stanford, Marion Buckwalter, is really fascinated by the fact that many stroke patients, even with relatively small strokes, have cognitive decline, following the stroke. There's also a lot of interest in these networks that are brain regions that are working together in various networks where you may be disrupting important networks with a stroke, and how can we overcome that and improve the cognitive recovery from stroke. So it's one of the big frontiers of understanding which stroke patients are most likely to have cognitive problems and how we can optimally treat them to help them recover more rapidly and avoid some of these complications of stroke. So neuro rehab is a really field that's also waiting to explode, I think, with a lot of, from stem cells to various devices to help our patients who have unfortunately had substantial brain injury recover from that, or use alternative networks to help them survive and have as normal a life as possible.
That's fantastic news.
Yeah, and absolutely. That's exactly the continuum of stroke care, starting from identification of stroke all the way to neurorehabilitation and secondary stroke prevention. So I think you summed it up very nicely. One last question. So, of course, you're a superstar in neurology, but what do you do outside of medicine?
Well, we had a band, all neurologist band called the Hypertonics that
Oh,
played
nice.
in multiple venues. Unfortunately, some of the most talented musicians were fellows who move on. So I like to play music, and have 5 kids who are very actively involved. Everything from a ballerina at the San Francisco Ballet that we enjoy going to see her, to water polo player, and we have a med student among the group. So lots to keep up with the 5 kids' activities.
Wow.
Quite busy. One thing I found real interesting is that you were able to take the diffuse trial to Congress. Can you just touch base on that? Because that must have been an experience.
That was amazing. Yeah, they do an award every year for the most impactful clinical trials, and they have a presentation at Washington, D.C. of the award winners, and then you go in and get to meet with some of the Congress people and talk about where healthcare is going and where they should be funding. So that was a great opportunity that happened after the Diffuse 3 trial came out in 2018.
I hope they listened.
Well, the funding has improved over the years. I mean, it's
Good.
still a real challenge to get your NIH grants funded, but I think there's a lot happening so that we can get larger stroke trials.
Sure.
Big effort by the NIH to do this program called STEP, where you're really bringing networks together so that when you have a study, you can quickly get it out to a large number of hospitals and get these things done more efficiently rather than starting from scratch. You've got a system that's up and running, ready to take the trials as they get funded.
That's fascinating. Dr. Albers, it's been a unique pleasure to have you on Brain Buzz. Looking forward to talking to you again. And thank you for everything you do in the field of stroke. And again, thank you for being with us today.
My pleasure. Thank you.
Thank you much. You've seen it all. You've done it all. Thank you.
Thank you. Take care.